So what we're going to talk about is the advancements in nutrition as we consider inflammatory bowel disease. And I do have a number of disclosures in terms of the fact that I've been very fortunate to have some grants for some of the research that we're doing, as well as to serve as a consultant and to be on the Nutrition for Kids executive committee. Importantly, as we think about nutrition for inflammatory bowel disease and what we need to know, we really have to put that into perspective of what the disease itself is. And so that is predominantly Crohn's disease, ulcerative colitis, and then this bridging area called indeterminate colitis, or IBDU, IBD undetermined. We discriminate that and differentiate that into the two different disease types predominantly as of Crohn's disease and ulcerative colitis. And the importance of that is basically that Crohn's disease is one that seems to penetrate through the entire mucosa down to the serosa and actually can involve the structures around it, versus ulcerative colitis that seems to be more on a superficial level within the mucosa itself. The symptoms of IBD, on the other hand, seem to be more related to where the disease is and how it functions rather than the disease type. So that if you have Crohn's disease that's isolated into the colon in the large intestine, basically that disease is going to work essentially the same way that ulcerative colitis does. So that if there's inflammation in the rectum, that actually causes more inflammation and diarrhea and pain than pain and that evolves from disease that's over in the right side where the small bowel meets the large bowel. The systemic complications of IBD are also prevalent for a number of patients. Approximately 25% of children will have growth failure. There can be eye inflammation or iritis. There can be kidney stones, bile duct inflammation, and gallbladder disease. You can have erythema nodosum, and arthritis occurs in a fairly substantial number of patients. What's particularly interesting as all of this evolves is that it seems to build over time. That is, that there's a genetic component that then seems to have this exposure to environmental factors, whatever they are, and we'll talk about that in just a moment. And then that seems to trigger something within the immune system, within both the innate and the adaptive immune system, that then goes into a change in the permeability of the intestinal tract and the microscopic disease that then manifests into clinical symptoms. That genetic component, we're starting to understand, not only just that there are these genes, but that each of these genes has a specific function in terms of affecting the permeability of the intestinal tract, the ability to resist bacteria, or anything else. We see that a lot of the genes that are present seem to be in both ulcerative colitis and Crohn's disease. And as you look at this, it actually becomes more of a puzzle piece where these things integrate together, and you have the colonization of bacteria and the loss of the protective flora that is there in terms of then the specific genes that are interacting with the mucosa. As that translated, the focus initially and for a long time has been very much on the immune system, and then that immune reaction to whatever the environmental triggers are. And that evolved into a look at the medications that were available in terms of either using them in what's called a step-up or a step-down technique, which basically means that you're simply using the same medications, but in the order that you use them changes. So that sometimes if the disease is very aggressive, we're going to be more aggressive with the medications, whereas if it's less aggressive, we're going to be looking at a step-up theory. But that, again, focused on the reaction to the initiating event rather than the initiating event itself. That's sort of like trying to treat the lymph nodes that you get inflamed with a strep throat rather than the infection that's leading to it. So the thinking about where we go with this is now changing. We're now starting to think about what we do before we reach that downhill slope and into disease. So in order to do that, we want to think about what's actually happening at the level of the intestinal mucosa itself. There is this complex, balanced flora that both Dr. Kleinman and Dr. Lewis already spoke about. And then there's this mucus layer as well as those tight junctions that regulate the permeability of the intestine. And that is true whether the disease is celiac disease or whether it's Crohn's disease or ulcerative colitis. And then the response to that is actually internal with those immune and inflammatory mediators. Now, the way I like to talk about it is actually a very elegant set of experiments that started with Balfour Sartor at the University of North Carolina. And what he did was he took a genetically modified mouse, okay, we're back to that genetic modification again, and looked at what happened if you exposed that mouse, which had an IL-10 deficiency, one of the immune-mediated deficiencies, and exposed it to a different bacteria. And what you saw is that if there was that mouse, it developed Crohn's disease on exposure. If you varied what that bacteria was, the location changed. If that mouse never was exposed to the bacteria, it never developed Crohn's disease. And vice versa, if you gave a normal mouse any of the bacteria, they never developed Crohn's disease. So it's a combination of both the predisposition to the disease and then what's going to trigger it. And again, we get back to that idea that it's that resident flora that's there, that's 10 times more than the cells in our own bodies. So that diversity changes enormously with patients who have Crohn's disease or ulcerative colitis. And the vermiculite relationship to the Bacteroides that are there is very different in the population of the patients that have Crohn's disease versus the normal population. What's interesting about that is we don't know what's the chicken or the egg. In other words, do you have Crohn's disease because you have that diversity change, or is it the other way around that you have the diversity change as a result of having that disease? There are other environmental factors that are there as well. Stress can exacerbate the problem. Non-steroidal anti-inflammatory agents can actually create the problem over time. Smoking is one of the highest risk factors for Crohn's disease getting worse. And we don't know much about food and food additives in terms of that at the present time. But we're starting to learn. And we're starting to recognize that there is a change as we go on in life, going from that embryo to the baby and what we feed. And then as we try to develop ourselves into who we are and becoming this person that's going to be able to handle the world and change it. So nutritional intervention has been very much in vogue in terms of thinking about this in terms of Crohn's disease and ulcerative colitis. In fact, that generated this idea that maybe there's a difference in not only what we eat, but what we're exposed to. And we got to this thing called the hygiene hypothesis, which was that if you're in developed countries, you're much more likely to have inflammatory bowel disease, whereas if you're in undeveloped countries or third world countries, you don't. So therefore, it seems that the hygiene hypothesis is that there is these exposures that is going to make a difference both in terms of allergic disease development as well as the development of things like inflammatory bowel disease. And so our treatment has changed. We've moved from trying to just simply relieve the symptoms to healing the actual surface of the intestine and changing the disease's natural history. We're trying to decrease the inflammation and immune modulation to now we're trying to look at tracking and treating the triggers and determining what we can do next. So the treatment goals for pediatric inflammatory bowel disease is, one, to induce remission and to achieve that mucosal healing, to maintain that remission and therefore avoid any relapse or flares, to minimize the complications that can evolve, including those that are both disease-induced and those that we induce with our medications, and then to maximize the adherence, because it never seems that the medications work as well when they're sitting up in the cabinet as when you take them. And then lastly, we want to improve the quality of life, which also includes for the kids promoting their normal growth and development so that they can function better both in school and with their friends. So the pathway to doing that has been a combination of using medication, surgery, emotional support, and nutrition. Much of it in the past has been focused on the medications. What we'd really like to change that to is changing it so that nutrition becomes the predominant factor that we use, medication becomes necessary a lot less, and surgery almost becomes non-existent, and we don't need quite as much emotional support over time. So the nutritional concerns for IBD are real, and therefore that becomes a focus of where we're going with this whole concept of nutrition. That's because 25% of patients who have Crohn's disease and ulcerative colitis do have weight loss. There is a decreased height for 25% of the patients with Crohn's disease. They can have low proteins, which decrease the tissue repair and decrease immune function. There's also dehydration that can evolve, as well as a number of patients can develop kidney or gallstones and lactose and possibly sucrose intolerance, because if you recall, the villi have the disaccharidases at the tips of them, and if the villi are destroyed, so are the disaccharidases that sit there. And so you're less able to tolerate lactose and sucrose. We did a study, in fact, of our patients in a normal maintenance population that was coming in for their routine evaluations. And we looked at 71 of our patients, and what we found, surprisingly, was the degree of insufficiency that the dietitians were seeing. In Crohn's disease, it was 65%. In ulcerative colitis, it was about another 37%. And in indeterminate colitis, it was approximately 57%. These were patients that either weren't getting enough calories, enough iron, enough protein, or enough vitamin D in terms of their diet. So we know that Crohn's disease and ulcerative colitis can both cause diarrhea, which wastes the nutrients and the fluids. They both have significant intestinal inflammation, which increases the nutrient needs and the losses as well. And both at the same time can respond to additional nutrients depending on the severity of the disease and how that nutrition is delivered. So there's also issues that are more Crohn's specific because of that thickened inflammation and the fact that it affects the small intestine where the nutrients are absorbed as opposed to the large intestine, which is what's predominantly involved in ulcerative colitis. As a result, with the small intestine being involved, there's less vitamin, mineral, protein, fat, and sugar absorption. As you might expect, the larger the area that's involved, the more there's going to be a problem with the poor absorption. When the lower part of the small intestine is involved, the bile is not reabsorbed, so it can't break down the fat as well. and it can also act as an irritant in the large intestine. When the upper part is inflamed, that's when you get the lactose and sucrose intolerance, because the disaccharidases reside in the first portion of the small intestine. And obviously, if you're not getting those nutrients absorbed, they then get metabolized into more osmotically active substances, and they speed the flow of the intestinal contents, causing bloating and less time for absorption. You also can have areas of stenosis or stricturing, which can increase bloating, nausea, and therefore decrease the appetite. And Crohn's disease can also cause the infections and inflammation, which increases the caloric needs as well as the nutrient needs. In terms of the vitamins and minerals that are needed, we've long thought that and recognized that vitamin D maintains the calcium in normal bones, but now there's a lot of studies that are starting to show specific immune components that have evolved from vitamin D sufficiency. And in fact, there's a theory that if you look at the population that's getting Crohn's disease, it's actually more in the northern United States and in more northern Europe than in southern Europe and in southern United States. Why? It may be because there's less vitamin D that's being absorbed through the skin in the north, and therefore that may be making a difference in terms of the actual disease evolution. Vitamin B12 is very much involved with the cell wall structure, and you can get anemia and neurological problems, and that's very much involved in being absorbed in the distal small bowel. Folic acid and folate are involved in the nervous system and in red blood cells, which is why it's also very important for pregnant women to be taking that through their pregnancy. Calcium is important in terms of the bone density and the ability to withstand fractures. And iron is not only important with anemia, but as you know, in tiredness and the ability to function in the classroom and at work. Zinc causes a slew of rashes, and it's often a loss of taste that evolves, and zinc is often lost when there's diarrhea. So, what do we do about that? Well, we started to think about how we can deliver nutrition. Nutrition played a very low thought process in terms of IBDologists in the country for a long time, because it was mainly focused, again, as we said, on the immunological component. We're now starting to see that there may be a difference in terms of using the Canadian version and the European version and the Japanese version, where nutrition becomes the primary therapy and is actually used instead of steroids for inducing that initial remission. And that's in part because parents and physicians are more worried and concerned about some of the risks that evolve from some of the medications that are being taken for the treatment. So as a result, there's been more pressure towards looking in that alternative space to find what else can be done for these patients. And as a result, those approaches are there. And this is one of my patients who has, as you see, an NG tube where he's getting nightly nutrition for his day. And then through the day, eats just a very little bit and continues on. There is what's known then as enteral nutrition. That's where the nutrition is delivered either through a NG tube, or that same fluid is taken orally, but it is just a single source protein and that they're taking. When it's their entire intake, it's called entire enteral nutrition, or EEN. And when it's partial enteral nutrition. With enteral nutrition, it can be compared actually to the drugs that are there. One of the ones that you may have heard of is Remicade or Humira or any of the anti-TNF drugs. With both of them, symptoms remit, they decrease. Growth improves, mucosal healings occurs in both, but not in the same proportion. The quality of life improves for both. However, there is food restriction that occurs and seems to be more of an issue for patients who have enteral nutrition. So a number of studies have been done. This was one that was actually recently reported where enteral nutrition, both partial and total, were then compared to the anti-TNF drugs. And this was done over an 8-week period and looked at whether or not calprotectin, which is a marker of intestinal inflammation, calprotectin being a stool protein that is a calcium channel protein that's important in intestinal function, is there and being excreted. And what was seen is that partial enteral nutrition resulted in remission in about 47% of the patients, whereas with enteral nutrition complete, it was 65%, which was comparable to the same remission rate that was seen with the anti-TNF drugs. The response rate is greater, as you would expect, because these are patients who are improving but haven't gone into total clinical remission. The calprotectin, as you see, fell significantly for the patients, particularly who did the entire enteral nutrition. What's interesting is when we talk about partial enteral nutrition and the studies that were done out of Philadelphia at CHOP, Children's Hospital of Pennsylvania, what you saw is that if they were told to take 80% of their calories as enteral nutrition, they actually only took about 50% of the calories that way. They actually took about the same number of calories through their enteral nutrition, but they supplemented it with a lot more oral nutrition of different proteins, which might make a very big difference into the response rate. The long-term effect is really noted here on the right side, and that is that 74% of the patients in Canada on enteral nutrition avoided steroids over a 3-year follow-up period. So it's a very effective way of using nutrition to change the outcome. How does it work? Well, there's maybe several ways, both in terms of its direct anti-inflammatory effect. Because it's a reduction diet, there's only a single protein source, as we talked about. There's also a decreased antigenic load because of that as well. In other words, if you're not eating a lot of meats, chips, vegetables, fruits, etc., the proteins that you're getting and the antigens that you're getting are very specific. There's no nucleotides that are there. The effect on the mucus and the modification of the microflora is there. But what's of note is that it works far better in patients who have Crohn's disease than patients who have colonic disease. The mechanism is still unclear. We don't know if it's because it just simply increases the diversity, whether it increases that short-chain fatty acid butyrate that Dr. Kleinman was speaking about earlier, whether it increases the protective species in the microflora, or whether it's simply the exclusion of harmful products that are normally in the diet. And that's been looked at with a number of different studies that are attempting to look at that. The impact of the induction therapy using enteral nutrition, as you can see, changes the way that the microflora are there and may have this effect on what we call dysbiosis and what's the negative impact of the microflora. What's of note, however, is that when this has been repeated, when you do it not just for induction, trying to make the original improvement in the patient, but repeat it over and over when they have a flare, it's not as effective. So that over time, the remission goes down from 92% to 77%. But again, that still means that it still works for about 3/4 of the patients. The weight gain, disease activity, and markers are better around with the first round, and the time to relapse is significantly better with the first round than the second round. But there's unanswered questions that come for that, because it's not something that you can sustain for very long. Most patients don't want an NG tube or to be just isolated onto oral liquids for their diet for much longer than about 6 to 8 weeks. So then where do you go next? There's resistance. There's the patient and the parent that are resistant. The insurance companies are resistant because it's an expensive way to go. And medical support is not there. And so we start to think about how we go about using something else going forward. So a lot of different things have been proposed. One, you could go back to the regular diet. But then there have been other people that have said, wait, let's still try to restrict things and change things and see how we can do. And of late, a lot of attention is focused on what's called the specific carbohydrate diet. This was actually promulgated back in 1924 by a doctor by the name of Sidney Haas, who used it primarily for celiac disease. However, one of his patients was this young girl in Canada whose mother, Elaine Gottschall, then popularized this in the 1940s with a book called Breaking the Vicious Cycle. And then from that, a lot of other diets have spun off. And I'm sure you've heard of them, mainly from a lot of your patients. They include the paleo diet, the maker's diet, and a number of other ones that have come out. Very similar. And the problem is that there's not been a lot of good science around whether or not they work until lately. And what happened is that we've started to look at this because many of my patients were coming in and saying, I don't want to go on those medicines you're suggesting. I'm going to do what I want to do and take what I want to eat, or I'm going to put my child on this diet. And when they did that, a number of them were doing better. So we started a prospective study to take our heads out of the sand and try to objectify the lessons that we could learn. There had already been a study out of Seattle that looked at whether or not this diet worked, and they looked retrospectively at their patients who had gone on the diet, and they found that generally they were improved within about 3 months. We at the same time looked at it prospectively. And the problem with doing that prospectively or retrospectively is, what do you depend on? What are you going to measure that's going to be accurate? If we simply talked about the parent's response, how's your child doing? Or asking them, are they having abdominal pain, or how much diarrhea they're having, there's the possibility that that subjectivity could come into it. So we wanted to objectify it because all of the traditional scores use either a physician or parent global assessment, really. So we tried to do that by incorporating some ideas along the way. The specific carbohydrate diet itself is not an easy one to follow, so you want to make sure that they're following it accurately. It's grain-free, lactose-free, sucrose-free, and the idea basically behind it is that the carbohydrates, because they're different forms of sugar, can fuel the growth of the bacteria that are not, as Dr. Kleinman said, the good bacteria, but actually the dysbiotic bacteria that could cause eventual overgrowth of bacteria and yeast. The thinking was that these carbohydrates could impair the enzymes on the intestinal cell surface, and as a result, the carbohydrates would become undigested and cause that fermentation and cause a lot of the symptoms. So by Dr. Haas's and Elaine Gottschall's things, it was restricting the carbohydrates that were available and only allowing those carbohydrates that were thought to be well absorbed in the original studies. It's a very difficult diet. If you look at the specifics of this in terms of the foods to avoid or the foods to include, it's not so easy. but we went ahead and looked at 16 children. We looked at all of those children in terms of ones who were able to not only go on the diet, but also who were willing to take a pill camera before and after so that we could actually objectify this and video see their intestinal tract in terms of measuring actual ulceration. We had 10 patients that were able to do that. However, one of those dropped out because she was in college and couldn't continue on the diet. As you can see from these, a number of patients were naive. They had been on no medications at all. And we only did this in a population of Crohn's disease. Others were on immunomodulators that were no longer helpful, and they were felt to be flaring. And as a result, we went and tried this and found that there were improvements in the hemoglobin, white cells, sedimentation rate, and albumins that were there but small and not clinically significant. But the measures that we typically use, what's called the Harvey-Bradshaw Index, that looks at number of stools and abdominal pain, was markedly improved. The PCDAI, the Pediatric Crohn's Disease Activity Index, markedly improved. And then what we did was what's called the Lewis score, or the LS here. That's a measure of looking at the intestinal tract for Crohn's disease on capsule endoscopy. There were ulcers that were seen, and they markedly improved. There was stenotic areas that decreased, but there were still ulcers for some. You can see this graphically presented here, where we looked and we saw the Pediatric Crohn's Disease Activity Index decrease to 12 weeks. We also looked at that Lewis score and found it improved by 12 weeks, where the ulcers that were in areas literally diminished as well. The patients, however, and their families said, well, wait a second, we really like this diet, we're doing well on it, we want to continue out to a year, and we're willing to do so. So we actually followed them out to a year and found that there was marked improvements and that these were sustained. What's interesting is that we're now about to report our patients out at 3 years. The patients who have remained adherent to the diet, a very small number, are actually doing fairly well. Those that are no longer adherent to the diet are all flaring and having problems. This is not the only diet that's been promulgated for Crohn's disease. There's a doctor in Israel by the name of Ari Levine who has a structured diet with the exclusions of gluten, dairy products, all animal fats, processed meats, emulsifiers in particular, and then low sugar, but he does not exclude nearly as many carbohydrates. There are 18 to 20 grams of fiber per day, and again, what his theory is that all of these high animal fats, the emulsifiers, the maltodextrins, and gluten seem to increase permeability and cause adherence and translocation of the bacteria. But his results are quite good as well. So he's looked at this in pediatrics as well as adult patients with Crohn's disease and seems to find a remission rate similar to what we found. We found ours to be about 86% on the small pilot study that we did. This was by 6 weeks, and they seem to be doing well. The problem with all of this is that these are very restrictive diets. They decrease the intake and potentially lead to weight loss. There's psychosocial and emotional burdens, particularly for the children who are following it adherently, and pitting some of them against their parents when they want to go off or they, quote, cheat. There are a number of potential deficiencies that can result. Folate, thiamine, and B6 can arise from limiting the grains. Calcium and vitamin D deficiency occur because of the dairy avoidance, and A, C, and potassium deficiency can come from limiting any of the fruits and the vegetables. So, is it there for everybody? No, it's probably not the best thing for everybody. So what do I tell my patients? I say that when you're well, consume healthy nutrients that are needed. Eat the foods that promote a healthier quality of life and that lessen your IBD symptoms. The ones that you can see with a symptom diary that make a significant difference. Include and focus on the foods that seem to help and heal and maintain a healthy intestine based on what we've seen, and exclude those food triggers when possible. And then make sure that you're getting about 20% extra calories and protein to improve your growth for the children and for the young adults. When it comes time of a flare, small frequent meals. Vegetable purees. Don't try to eat big chunks of high residue foods like broccoli, where the stems or the florets could actually impinge into an area that's narrowed. Avoid the triggers of diarrhea or pain. That's typically spicy and greasy foods. That's typically dairy products, and particularly lactose, because of what we spoke about earlier. Recognize that vegetables and beans that have large amounts of fiber can be problematic. Colder beverages and caffeine seem to cause more cramping. And keep that symptom diary so you can identify those problems that are there. Look at your iron. Iron becomes a very important factor. There's the issues of blood loss, decreased absorption, decreased appetite and intake that's there. When you're feeling badly, you're not getting it as much. Food selection, a lot of times you're not able to eat foods that are high in iron. And remember that even though vegetables are often high in iron, they're very tightly bound to the phytophosphates and to other foods, substances that are there. There is an increased demand, particularly in heavy exertion, pregnancy, and simply inflammatory bowel disease. You can screen this, and we often do, with iron, total iron binding capacity and ferritin, and it should be treated. And if they can't absorb it orally, we treat with IV. Look at vitamin B12 as well, because that can also be an issue. The symptoms can be anemia, nerve damage with tingling, numbness, and poor balance, poor vision, and delusions. If you're on a vegetarian diet, you're not getting B12. The B12 comes from animals, meats, fruits, fish, and shellfish, poultry, eggs, milk, and some cheeses. And many patients have problems because they're on acid blockers that interfere with complete B12 absorption. Those with severe disease of the terminal ileum or surgery there are at particular risk because that's where it's absorbed. And blood tests can detect the deficiencies once again and make sure that B12 is added to the grains that you're eating if you are a vegetarian. In some, it's really about looking at what's applicable. For Crohn's disease, Enteral Nutrition seems to be there. We're now studying specific carbohydrate diet in ulcerative colitis as well as Crohn's disease. The CD diet from Dr. Levine is applicable for Crohn's disease. We did look at probiotics, and as Dr. Lewis indicated before, the trial was stopped because we actually found that the patients on placebo were doing better. And it seems to be that idea again that bacteria causes immune overreaction. So if that's the case, it doesn't matter whether it's a probiotic that's being put into the system or any other resident bacteria that's causing an infection. Curcumin, which is in turmeric, has actually been shown to be very effective in ulcerative colitis and limiting problems. There are new studies looking at essential oils. There's questions of whether food allergies may have an impact. We do know, however, that specific nutrients are helpful, as we just discussed. With IBD increasing and widespread, the patients and parents are looking for alternatives. And therefore, the major alternative that's logical is to focus on nutrition. Enteral therapy becomes an important option for induction. And exclusion diets may be effective long term. We just reported that when we looked at patients who are on long-term diets with the specific carbohydrate diets, they report that they're continuing to do well. Of course, that means that the patients who were on them and are no longer on them aren't doing as well. Much research needs to be done. And as we try to follow this, hopefully you'll be able to follow it on Nutrition for Kids, where we'll hope to continue to report some of our results. So with that, I want to say thank you to all of you.